Good afternoon, everyone. We'll go ahead and get started. Welcome to our final session of the day regarding health disparities in data. And so today's speaker is going to be Dr. Jeffrey Linder. Dr. Linder is a general internist and primary care clinician investigator. Dr. Linder is the Michael A. Gertz Professor of Medicine and the Chief of the Division of General Internal Medicine at the Northwestern University Feinberg School of Medicine. Dr. Linder's research focuses on the care of ambulatory patients with acute respiratory infections, the #1 symptomatic reason for seeking medical care in the United States, and the appropriate use of antibiotics in ambulatory care. Dr. Linder has expertise in electronic health records and clinical decision support, as well as using behavioral science and social psychology to understand and change behavior. Dr. Linder served on the outpatient antibiotic use target setting work group convened by the Centers for Disease Control and Prevention and the Pew Charitable Trust, the Antibiotic Stewardship Research Workshop Planning Committee of the Society for Healthcare Epidemiology of America, and has served on advisory or expert committees for the National Committee on Quality Assurance, the Joint Commission, and the Infectious Diseases Society of America. He received his medical degree from Northwestern University, did a fellowship in general medicine and primary care at Massachusetts General Hospital, and he has a Master of Public Health degree from the Harvard T.H. Chan School of Public Health. Please join me in welcoming Dr. Linder.
Thank you, Albright. I've got the home crowd right here. Great. Okay, 3:45. I'm trying to end my comments at 4:30. It's the last talk of the day. We all want to go home, and hopefully everybody's caffeinated and not too warm in here. Okay, so a few conflicts of interest. I have grants and research support from various institutions. I'm on a couple of advisory board memberships that were mentioned. I have investments in Eli Lilly, Amgen, and Biogen, and nobody else is responsible for what I'm going to say today. It's all me. So here's what I'm going to talk about. First off, I want to go over some definitions about disparities in equity. Want to give kind of a national perspective on where we are with healthcare disparities in equity. Spend a fair amount of time going over antibiotic use disparities, and then at the end address antibiotic use equity. I wrote here addressing antibiotic inequity, but let's actually shoot for going for equity. My other disclosure is I was invited to give this talk and immediately felt a little bit of imposter syndrome because through my career in health services research, I've worked adjacent to quite a number of people who are card-carrying disparities and equity researchers. And I've never sort of focused on this myself. And so, I continue to learn about health disparities and health equity. But as I researched this topic, realized pretty quickly nobody has done work in this area about really pulled together disparities in antibiotic prescribing and then advancing equity in antibiotic prescribing. So the whole field is actually kind of exciting and nascent. And one of the reasons why I'm going to try to get to the end of my comments by 4:30 is I actually would like much more to have a conversation with the group here about your thoughts about where we should go next. To the point about this being a nascent field, as I was researching the talk, I ran into this webinar that was hosted by the CDC. I know and am extremely fond of almost everybody on this list up here, and they were talking about exactly what I'm supposed to talk about, but didn't really kind of advance the topic as much as I was hoping. I was hoping like, this is the answer, this is what I'm going to tell the audience. But they talked about a lot of stuff I was sort of familiar with. So, all right, let me get into some definitions. And just to really, really level set, because we don't usually talk about disparities in the context of antibiotic use, I actually want to go all the way back to the Institute of Medicine Unequal Treatment Report from 2003. And of course, like I said, people that I had been adjacent to, so John Ianian comes to mind, Lisa Cooper, Leroy Hicks, have been doing research surfacing and describing disparities in care for a couple decades prior, but they have this nice diagram in the IOM report where they described a disparity as the difference in care between, as they said at the time, a minority group and a non-minority group. And with the quality of healthcare higher on the y-axis. And reasons for these differences could be because of clinical appropriateness and need and patient preferences, which are fine. Like those could be legitimately different. But it also could be the operation of healthcare systems, legal and regulatory climate, or discrimination, biases, stereotyping, and uncertainty. And those latter two categories, that's sort of where the disparity is. Like that's not right, okay? That is not the highest quality care we could be delivering. So a couple definitions, and you'll notice I pulled a fast one. I changed the title on you. It was describing disparities and advancing equity, which is not what was in the program, because I want to make a distinction between the two. So health disparities are population-specific differences in the presence of disease, health outcomes, or access to healthcare based on some population differences. And health equity is individuals achieving the highest level of health through the elimination of disparities in health and healthcare. And in fact, I'm realizing I think this might be a different slide set. Yes, this is the draft slides because I changed the definition. So there it is. And I'll tell you why I changed the definition. There we go. So by definition of health equity, I actually pulled together definitions from the CDC, the WHO, and then Health and Human Services. What you'll notice here that wasn't in what I just showed you before is fair and just opportunity. So sticking that in. So the WHO, so individuals, health equity is individuals achieving through fair and just opportunity their highest level of health, right? So health equity is a much more positive concept than health disparities. And disparity dimensions, often we think about this in terms of race and ethnicity, but this can be due to gender, socioeconomic status, age, geography that I'll touch on, language, citizenship status, disability status, or sexual identity and orientation. So these can all be dimensions that lead to disparities and that we may want to be looking at. And to also make this difference between disparities and equity a little bit clearer, this is actually from a publication that came out just a couple, I think it was a month or two ago, that was in JAMA that looked at the economic burden of health inequities, and they took very much a health equity view. Along the y-axis, let me start there. So that's coronary artery disease deaths per 1,000 people, right? So lower is better here. And unhelpfully, usually we would sort of, the whites are way over on the right side in this graph. And whites have a certain death rate. In this example, it's higher for Blacks and Native Americans, or sorry, Native Hawaiian and other Pacific Islanders, and lower for some other groups. The disparity is between the majority group and non-majority groups. Equity is some other target that doesn't presuppose that in this example, the white rate is the right rate, okay? So we want to actually be shooting for health equity. And actually, just as an aside, the take-home point from this paper was that health inequities cost us a lot of money. So in the abstract, they talked about total health inequities for non-whites populations in the United States was $421 billion or $450 billion, depending on what method they used. But, and I'll come to this point in a minute, you'll notice health inequities for whites collectively is actually even higher because it's a larger group. And I'll touch on that in a second. How are we doing? No big surprise that there are disparities in quality of care by race and ethnicity in the United States. The Agency for Healthcare Research and Quality every year puts out a healthcare quality and disparities report. This report is a little disappointing because it's much more heavy on healthcare quality and not quite as heavy on disparities. But if you go to one of the appendices, you can find this report that shows disparities in quality of care by race and ethnicity compared to white patients for a whole variety of metrics. And the metrics depend on what groups are being compared. and with the non-white groups having worse quality of care, the same quality of care, better quality of care in orange, white, or blue colors. And this shouldn't surprise people that there are lots of metrics for which quality of care is not as good for non-white groups as for whites in the US. So, and AHRQ comes out with this every year. So a tricky thing with antibiotic prescribing, particularly for those of us who do outpatient stewardship, we're much more focused on overuse than underuse, right? And so this was a systematic review done by Nancy Crescent and Pete Groneveld, where on the x-axis it was the need and appropriateness or benefits of some type of care being given, right? So more to the right, the more care that needs to be given. And on the x-axis is the likelihood of receiving it for the procedure. And so they sort of divided this into 4 quadrants, and disparities and quality of care research is generally focused on kind of the right side here. So higher quality things. So does the patient with an MI get an aspirin or not? Right. And so, more is good, but there are circumstances where optimal care is actually less care. Okay. And antibiotics often fall into this lower left-hand quadrant, and the disparity could be in getting too much care for non-majority groups. This was also a paper that, and actually I'll say it here, right? So in this systematic review, they were particularly looking at overuse among whites and focused on that. And some examples they came up with were cardiovascular care, so that whites probably get too many implantable cardioverter defibrillators. In cancer care, much more surgery or radiation for prostate cancer. And then other domains like inappropriate imaging for low back pain is more common in whites. Getting opioids and benzodiazepines. So this was that perverse disparity where whites were more likely to get, or whites continue to be more likely to get appropriate and inappropriate opioids, leading to higher death rates among whites too. And then they also focused on antibiotics. And when I looked over the list of papers for antibiotics, several of my own papers were in the bibliography, and I started to get a little bit over my own imposter syndrome a bit. I was like, oh, maybe I have sort of done this a little bit before. Okay, so that's just talking about a few definitions, disparities and equity. But I also want to here's where I'm going to antagonize the audience a little bit. If some of this might make people feel uncomfortable, I have a feeling the people who have chosen to come to this this talk are going to be a little bit more receptive to the ideas here. But many of our colleagues are not quite as accepting of this. Talking about even talking about white people makes people uncomfortable. And actually, I'm going to look at sort of the white members of the audience here a bit and commend a book to you. So if these discussions make you or your colleagues uncomfortable, I strongly recommend the book White Fragility. It is written by a white woman for white people to sort of talk about issues. And I will say, I had the chance to reread the foreword by Michael Eric Dyson 2 days ago, and the first chapter, he actually quotes Beyonce, who has said the phrase I had on the slide before. So I think he said, no less of a star than Beyonce has, said that phrase. But I strongly commend the book White Fragility for you to read. And then for everybody, if you haven't read The Sum of Us by Heather McGee, it has a really, it has an awful start because it's about why desegregating swimming pools in the United States in the 1910s and 20s sort of led to the closing of these large public swimming pools and the growth of, there's actually, I've heard from somebody else, like a beautiful country club down the road that I'm sure was whites only, in the 1930s. But she actually makes the case that gets back to what I was alluding to when I showed you the economic impact of inequities, that yes, of course, these disparities fall more heavily on an individual basis on Black Americans than other groups. But if we implemented things that would help Black Americans in aggregate, whites would be helped more. There's just more of us, right? About 60% of the population. And so she looks at, we're talking about healthcare, but she looks at education, housing, and other domains. So these two books are fantastic. Also from the national perspective, happen to run into the fact that Healthy People 2030 actually has reducing inappropriate antibiotic use in outpatient settings. So if you're looking for, this is a national hook into this whole discussion. So Healthy People 2030, yes, it's developmental, but I was not aware until I was preparing for this talk that actually Healthy People 2030 has reducing inappropriate antibiotic use in outpatient settings as a developmental goal. So that's good, because Healthy People 2030 has a very strong focus on addressing health equity. All right, so if you need to go talk to people, we're often using the Joint Commission against our colleagues. Here's where we can use Healthy People 2030. And if you look at sort of the frameworks of Healthy People 2030, they talk very much about health disparities, health equity, health literacy, well-being, and then the social determinants of health too. So, and the ones that they called out here were economic stability, education, healthcare, neighborhood and the built environment, and social and community context. So that is a good hook into the whole conversation if you're trying to engage people back at your home institutions and organizations. Okay, so let me flip over to antibiotic use disparities. So a couple colleagues of mine and I were interested in the quality of outpatient care delivered to adults in the US. We published this in 2016 in JAMA Journal of Medicine. And we looked at a whole host of quality metrics. And in particular, we were looking at overuse metrics. This wasn't explicitly about identifying healthcare disparities, but I actually wanted to, and I'm going to very quickly, so showing inappropriate treatments, and here higher is almost always better. So we're trying to avoid inappropriate care. And let me actually just skip to the punchline in the interest of time here. That so the bottom line here is avoiding inappropriate antibiotic prescribing. So how often did somebody who came in for a diagnosis that shouldn't be treated with an antibiotic got an antibiotic? Colds, flu, acute bronchitis. And at the bottom here, you see that unfortunately, like we failed to avoid that. Sorry for the double negative. About 40% of the time. And then based on these data, this is unpublished, but are able to look at differences in that failure to avoid inappropriate care by income. So I want you to actually focus in on the yellow lines, right? So there's the yellow line with the circle. So that's antibiotic use among those who have greater than 400% at the federal poverty level. And the yellow triangles, that is antibiotic use among those whose family income is less than 125% of the federal poverty level. And there's a disparity there. So no shock that that those with higher income are receiving more inappropriate care, right? No big surprise. Another interesting thing, just in the whole context of discussions about disparity and inequities, is the diversifying nature of the US population. So, right, I showed you the graph before, and this isn't meant to be an eye test. You don't have to pay attention to this yet. But showing you disparities. But while all of this is changing, this was from another publication we had that was related, that was looking at the differences in quality of care for those with and without primary care. But what I actually want you to focus in on here is the differences in the populations between 2002 and 2015. So the population is actually getting a little bit older. So particularly if you look across at those that are about in their 60s, the population is going up. But more interestingly, if you look at race and ethnicity and the nature of these data, we had to conflate race and ethnicity. The proportion of non-Latino whites decreased from 71% of Americans in 2002, and I should say these are all nationally representative data, to 64% in 2015. And the proportion of Black Americans, 11% to 12%, a larger increase in Latino Americans, 12% to 16%. And so just sort of keeping that in mind, we live in a diversifying United States. Okay, and then there have been some recent reviews about differences in antibiotic prescribing by race. But I had to sort of go back to what to me is like the original publication that kind of discovered for me that way back in the dark ages of 1997, that there were problems in outpatient antibiotic prescribing. So this is by Ralph Gonzalez and John Steiner, so antibiotic prescribing for adults with colds, upper respiratory tract infections, and bronchitis. And even in this paper, they found that there were differences between white patients, that Black patients were less likely to get antibiotics, and those of other race were less likely to get antibiotics than whites. And what I had failed to remember is that they even referenced an earlier paper by McCaig and Hughes that was from 1995 that also found something similar. And the metrics here are a little bit different. So this is the annual antimicrobial drug use by age, race, and sex in the National Ambulatory Medical Care Survey. And again, published in 1995. But so these data are probably at least from 2 years earlier than that. And on a population basis, sorry, on a population basis, you'll see that, and they only had for race white and Black, but white patients in 1980 getting 412 prescriptions per 1,000 people per year, Black patients getting about 300 patients per person per year. And then by 1992, antibiotic prescribing had increased a bit, but that disparity remained. Okay, so still 441 versus 386. And then had to go, like, this is one of the first papers I published was about antibiotic prescribing for sore throats by primary care doctors, again, using the National Ambulatory Care Survey from 1989 to 1999. And right, ancient history, this was published in 2001. And had a similar table in which we found lots of inappropriate prescribing. The right antibiotic prescribing rate for sore throats for adults is probably about 10%. And we found it was way higher than that. And then highlighting the racial and ethnicity differences here, there was a significant increase in among whites, and I'm so sorry, there was a higher rate of antibiotic prescribing among Black patients coming in with sore throat, but a lower prescribing of appropriate antibiotics among Black patients. We did the same thing for children and found that non-white patients were less likely to get either an antibiotic or a recommended antibiotic among those who got an antibiotic. So these exist too. And then one point I want to make about quality of care. I'm just going to use another paper we did. So we did this paper that looked at antibiotic prescribing over the course of the day. And we were mostly interested in how physician behavior changes over the course of the day. And so we were trying to isolate antibiotic prescribing for patients coming in with respiratory infections for each hour during a morning clinic session and an afternoon clinic session. And I don't, how many of you have seen me present this graph? Like, you guys know, you've seen this before, right? So for those who don't, on your honor, like, what do you think we found? Okay, less antibiotics in the morning. Okay. right? So we found, and if you focus on the middle line is the overall antibiotic prescribing for respiratory infections. So we found an increase in antibiotic prescribing over the course of the day, and a increase over the course of the afternoon. The odds ratio for getting an antibiotic when adjusting for a whole bunch of factors, and I'll come back to that in 1 second, comparing the 4th hour of a clinic session to the 1st hour of a clinic session was 1.26. So there were 26% higher odds of getting an antibiotic at the end of a clinic session than at the beginning. The main point I want to make here is about adjusting for things. So in doing this, we're interested in the independent association between the time of day and an antibiotic prescription. And in giving this talk, I actually went back to look at, like, what did we adjust for, right? And it turned out when you look at the data, white patients were more likely to get antibiotics than black patients. And so we adjusted for that in that model. Okay, so we adjusted for race, which, if you're trying to isolate the independent association between the time of day and the antibiotic prescription, is okay. But if you're trying to do anything else, or you're trying to talk about a disparity or an inequity, do not do that, right? That is not good. So, you know, we have basically mathematically in this model said it's okay that white patients are getting more antibiotics than black patients. That's sort of like implicit in the modeling. So whenever you see data like these, like, know what the investigators are doing. We tried to adjust for everything we could, right? Same patient, same diagnoses. We adjusted for clustering by physician. So like the same doctor at the end of the day is different than they are at the beginning of the day. But the main point I actually want to make here is, like, if you're looking at quality of care and looking for disparities, like, it is not okay to adjust for race. This actually just came out this year, and I was so excited to see that this paper, National Disparities in Antibiotic Prescribing by Race, Ethnicity, Age Group, and Sex in the United States Ambulatory Care Visits, 2009, like, this is the, this was the answer, the paper I was looking for. Something is seriously wrong with this paper, and I actually got a email from a medical student at University of Michigan who we're working with, who was looking at these same data. There's something wrong with these national data, and I'll show you in a second. And I think there's a reason, with all due respect to the journal Antibiotics, like, there's a reason this was published in Antibiotics, which is an open access journal. But so they looked at the NAMCS is the National Ambulatory Medical Care Survey from 2009 to 2016. They looked at oral antibiotic prescriptions, and they used an appropriateness criteria that Catherine Fleming Dutra and a whole bunch of us kind of put together in this publication that was in JAMA in 2016. So they said, yeah, we use that method, and they found, not surprisingly, disparities by race, where whites were getting slightly fewer antibiotics than black patients. That's the lighter horizontal line, and then the appropriateness of it, that's inappropriate antibiotics is the black line. That whites were getting fewer inappropriate antibiotics than black patients. But the problem was, I sort of delved into this deeper, and I cannot make these data make sense at all, where they found that 64%, like, let's say, just looking at that, like, for white only patients, inappropriate antibiotic prescribing was 56% of antibiotics. Like, there's a lot of inappropriate antibiotic prescribing, but the way they did this just seems wrong. So I'm sorry I even brought it up. Okay. A comment about insurance. So I already alluded to income. We've talked about race, insurance. This is with the same medical student I just alluded to a minute ago. So we're looking at the 2016, 2018, and 2019 National Ambulatory Medical Care Survey, and looked at an estimated 413 million visits by children, at which 17% of them got antibiotics, and then 1.2 billion estimated visits by adults, of whom 11% got antibiotics. And I forget, one of the speakers earlier today sort of may have alluded to the fact that, right, in ambulatory practice, about 10% of visits are associated with an antibiotic prescription. And so that bears this out. They controlled for patient factors. And again, we've controlled for race here, for calendar quarter, because antibiotic prescribing, although it shouldn't, goes up in the winter. and then adjusted for clinician specialty, and found that among children, those who had safety net insurance, so that's Medicare or uninsured, had a lower antibiotic prescribing rate than children with private insurance. For adults, it was the opposite, where adults with Medicare or no insurance got antibiotics at a higher rate than, or a higher rate of inappropriate antibiotics than adults who had private insurance. So we're still working on this stuff. And actually, this came up in the last section. I'm so sorry if she's here, because I was going to throw like one of our attendees onto the bus who was like, you know what the problem with antibiotic prescribing is? It's the urgent cares. And looking at Dr. Ritter, who works in urgent care here. But the site of antibiotic prescribing does matter a little bit. This is a little complicated, but it's showing you both the visit volume, the rate of antibiotic prescribing, and the rate of inappropriate antibiotic prescribing at 4 different sites of care. And I actually want you to start with the offices, so physician offices on the right side. The first thing to notice is the darker purple, although it's hard to see in the light here, the darker purple is the number of visits in millions. So there's like 160 million visits to physician offices. The reason you don't see a dark purple line for the retail clinics, the emergency departments, or the urgent care clinics is because they're so tiny and so rare relative to physician offices. So as much as those of us who work in offices like to complain about retail clinics and urgent care clinics, like the volume of visits at offices is way bigger. Like that's where if we're going after outpatient antibiotic prescribing, like that's where the money is. Not surprisingly, focus on the lighter purple. The proportion of visits where there's an antibiotic prescription is way lower in offices because we see many more things than you do in retail clinics, where a lot of people come in with respiratory infections, or emergency departments where they see a variety of things, or then urgent cares that see a lot of respiratory infections. So the antibiotic prescribing rate is high. And then the last thing is the proportion of inappropriate antibiotic prescribing, where, and again, right to left, offices, it's sort of that 15% range. Retail clinics do actually a little bit better than we do in physician offices. It's worse in emergency departments, and it's worst of all in urgent care. Sorry, Dr. Ritt. But so there are disparities in antibiotic prescribing by where you choose to get medical care. Not surprisingly. And then more recently, I and colleagues have tried to get our hands around all antibiotic prescribing. So I've talked about a lot of stuff. I've talked about is respiratory infections, sore throats, bronchitis. We actually tried to come up with something to assess the appropriateness for all, at the time, 94,000 ICD-10 diagnoses. So we said, like, for every one of those 94,000 ICD-10 diagnoses, is an antibiotic appropriate, possibly appropriate, or appropriate? And in this analysis, we looked at market scan data for 2016 and found that 13% of 15.5 million antibiotic prescriptions were clearly appropriate. So diagnoses like pneumonia, cellulitis, things like that. A big proportion, 36%, were potentially appropriate. Things like sinusitis, pharyngitis, where it may or may not be appropriate. 23% were inappropriate, like routine healthcare visit, annual checkup, things like that. And then sort of most horrifying to me is that 29% were not associated with any diagnosis code whatsoever, right? So there's that's a whole other talk I can give. But we've used the same methodology in looking at Medicaid data that actually does have race and ethnicity attached to it. And so in this data set, doing sort of something similar, we looked at 300 million Medicaid prescriptions between, and I think it was like 2002 to maybe 2014, that what proportion of those antibiotic prescriptions were associated both with a clinician visit and infection diagnosis, 55%. What proportion of visits were associated with a clinician visit and no infection diagnosis, or even being a little bit more forgiving than what I showed you in the last slide, 17%. And then what proportion were associated with no clinician visit, which was 28%. And then in preparing for this talk, we actually had data about about patients' race in the Medicaid data. And so you actually wind up seeing that white patients are more likely to make, and I should say, for these data, we a priori said that a difference of 5% is significant. We didn't do the usual statistical testing because with 300 million visits, like any tiny little difference would be statistically significant. So these are not, we didn't say any of these differences were clinically significant, but there are subtle differences between white patients with Medicaid being a little bit more likely to have their antibiotic use associated with a clinician visit and a diagnosis of infection. Black patients for it to be there to be a clinician visit and no diagnosis of infection, and then across the board it was just the same for the proportion of antibiotics associated with no clinician visit whatsoever. Okay, and then one other, this came out recently too. So influence of factors commonly known to be associated with health inequities and antibiotic use in high income countries. This is done by a group, I think they're in the, you guys can see better, yeah, Nottingham. So in the UK, they tried to pull a lot of these data together, and the results are not gonna be too shocking to you, but they did a systematic review and to try to figure out what evidence is there for an association between elements of health inequities in dispensing, prescribing, and use of antibiotics in high income countries. They looked at 58 papers, 64% were in the community, 22% were hospital-based, and 14% were cross-sector. 59% were in the US. And then for those of you who do outpatient stewardship, I do have one paper for you. I know a lot of this has been outpatient, but it's coming. And found a whole raft of, they did a nice job of summarizing. So if you're looking for a reference to sort of summarize these data a little bit, this is decent. And actually, if you just sort of focus on what they refer to as the factors on the left and the summary of results, so age, older folks are prescribed more antibiotics. Pregnancy and maternity, younger pregnant women are likely to get more antibiotics than older pregnant women. White pregnant women more than non-white pregnant women. Race and ethnicity, an association between race and ethnicity and antibiotic use, particularly in acne and dental infections, they said. I mean, despite all the stuff I had said a minute ago, women had higher antibiotic use than men. Sexual orientation, men who have sex with men actually receive more recommended treatment for Neisseria gonorrhea than other men, which is interesting. And I think that gets to like site of care. So men who have sex with men are probably more likely to go to dedicated clinics that better adhere to guidelines. I think that's what's going on there. Other socioeconomic characteristics that I alluded to before. So income, so high income resulted in both increase and decrease antibiotic use depending on the healthcare setting and country. Insurance, patients with no insurance were less likely to be prescribed antibiotics. Employment, not found to affect antibiotic use. Deprivation, so this is a European phrase for we more commonly call this socioeconomic status or area deprivation. Areas with high deprivation and higher antibiotic use compared with areas of no or low deprivation. And then education, higher education resulted in improved awareness regarding antibiotics and more what they describe as rational use. And then finally, urban versus rural areas. It depends. What we often see in the United States is rural areas have higher antibiotic use, generally speaking, than urban areas. And the UK and USA found geographical variation in antibiotic use. And then migration. And I think this like elides a whole amount of research that Larissa Gregorian has done about non-prescription antibiotic use. So they say differences in accessibility to antibiotics across countries. Patients who face barriers to obtaining antibiotics were more likely to seek alternative routes of supply. And so like in the United States, if you think about immigrant communities often have other means of obtaining antibiotics compared to kind of via a physician visit. Okay, here's one inpatient example for you. So variation in race in antibiotics prescribed for hospitalized patients with skin and soft tissue infections. And again, complicated, but the main thing I want you to focus in on here is the recommended first-line antibiotics, cefazolin, prescribed to 13% of white patients and 5% of Black patients. And this is using Vizient data, so this is sampled nationally representative data. And then if you look at clindamycin, so white patients, only 7% received clindamycin, whereas 12% of Black patients received clindamycin. And then importantly, the investigators here have adjusted for what day the person was in hospital, penicillin allergy, whether or not they were in the ICU, MRSA status, and whether the patient had diabetes. So adjusting for everything they could, they still found these significant differences between white and Black patients, with white patients more likely to get first-line recommended treatment. And then I already alluded to regional variation in antibiotic prescribing. And this was by a group from the CDC that looked at the United States in 4 regions. So often there's a thing in antibiotic prescribing where we found that the West is the best, but it's more complicated now, and I can get into that if you want. And so what they did was they looked at the likelihood of getting an antibiotic in 4 regions in the United States, so the Northeast, the Midwest, the South, and the West, and across 3 tiers of antibiotic appropriateness. So the top one, tier 1 antibiotic, sort of similar to what I showed you before. Antibiotics always indicated. In the middle, antibiotics sometimes indicated, and at the bottom, antibiotics rarely indicated. They said, in comparing to the West that had the lowest overall antibiotic prescribing rate, there's no difference among antibiotic prescribing in that top tier of antibiotic appropriateness. There is no significant difference in the middle tier, and all of the differences in that low tier. So antibiotics rarely indicated. There was a significant difference between the some of the regions and the West with the other regions. And then when you look at this sort of a slightly different way, if you look at the antibiotics rarely indicated in the West as the referent and sort of like grow out from there, you basically see the same thing. So that the not surprisingly, as you go up in antibiotic appropriateness, like you would hope that the antibiotic likelihood prescribing would go up. But then as you look across the different regions, you see much higher antibiotic prescribing rates in some of the other regions compared to the West. And I think we've seen this graph earlier today, right, where there's higher antibiotic prescribing rates in the South. And the authors of this paper made a comment about Southern culture, like we had to address Southern culture. And I work with a sociologist, Julie Simzak, who is at University of Utah, and she's a sociologist. And so as soon as you say culture, it gets really complicated. And I knew she was going to go berserk when they're like, "What do you mean Southern culture?" And so she actually invited her to write an editorial with me about like cultural variation in antibiotic prescribing. You know, because the authors were sort of alluding like we need to fix the South, like there's something wrong with Southern culture. That's actually not that helpful. It's too big of an area, and like getting your hands around Southern culture as a cause for antibiotic prescribing is not a workable solution. So, so she sort of, we had a little bit of a field day about talking about that. Okay. So now what last few minutes, and then actually I want to get to talking about this a bit more. So addressing antibiotic inequity, so what do we do about this? So I can go on and on of kind of the litany of these disparities. And to me, we actually need to do several things. So I feel like we actually need a better conceptual model of both disparities and inequities in antibiotic prescribing. And trust me, I looked long and hard in preparation for this talk about like, somebody has to have done this. This is like the economist fallacy, you know, the thing about like the economist is walking with their kid and there's a $20 bill blowing along and the kid says, you know, "Mom, there's a $20 bill." And she says, "There can't be, because if there was, somebody would have picked it up already." And I feel like somebody should have done this already, but haven't really found anything. So I actually want to show you, I just drafted something up, and we'll see. I'm curious what you guys think. We need to measure this, and I have a comment about that. We need to actually give prescribers feedback, and this will make people uncomfortable, like feedback about their prescribing by these classes, including race. We definitely need to be thinking about inclusion of diverse participants in clinical trials and research, and then also workforce diversity. is important too. So just a couple comments about each one of these. So the conceptual model. So I have put in a grant proposal and often have this like very simplistic thing as I'm trying to explain the specific aims to reviewers, where the patient has some symptom, they go see a clinician, the clinician prescribes an antibiotic, the patient fills the antibiotic, and then the patient takes the antibiotic. Duh. Okay. And so others have thought about and I showed the skin and soft tissue infection. So Otube Essien, who is now at UCLA, he just moved from Pitt to UCLA. He and a group at Pitt coined this phrase pharmacoequity, and usually talking in the context of getting the best medicine to all patients anytime we can. And he talks about the ABCs. He's like, I want to keep it simple and talk about the ABCs. So actually, I'll come back to the appropriateness in a minute. But Dr. Essien talks about ABCs are access, bias, and cost. And the cost and access are a little bit different. And so access to me, I kind of broke that apart too, but you need insurance and things like the Affordable Care Act and getting people insured and having health and medical coverage is important. Access to primary care, access to specialty care, both important to getting the right treatment, and access to a pharmacy is important too. And there's a whole literature about the distribution of pharmacies in the United States that we can get into too. B is bias. So, what are the reasons for that clinicians are prescribing antibiotics for whites more than blacks as an example, and then cost. So we'll talk about that. A tricky thing is I stuck in the appropriateness box here too. That is a sticky wicket for this whole conceptual model, because it's not as easy as saying, well, people who have a heart attack should get a beta blocker, right? Here it's a little bit more complicated for infectious diseases. Like, do we have the diagnosis right? What is the right thing to do for the patient? So that makes this a little bit more complicated. And I will say, Dr. Essien, he is focused on prescribing newer anticoagulants for Black patients. He has a fascinating literature on that. This is actually more complicated because sometimes you should get it, sometimes you shouldn't. And then, this is shot through with both health policy and then fitting in systemic racism too. And that actually gets back to this pharmacy issue and many of the other issues. And I'm picturing some model that's got that wrapped around everything else. But, those of us in the room, as I'm describing this to you, I haven't seen anybody else sort of put this together in terms of equity for antibiotic prescribing. So let's talk about that. What am I missing? Where do the arrows go? Let's talk. Okay, I mentioned reporting feedback. Here's where here's a report I get about my so we have a quality committee and we have a quality equity subcommittee too. And one of the first things we're doing is looking at equity in influenza vaccination. So I now get a report that shows the proportion of my patients who get their influenza vaccine stratified by race and ethnicity. So you'll see, and I have a disparity here. I don't know how well you can see it here, but so my disparity between my Black patients and white patients, my white patients get influenza vaccines 8% more than my Black patients, and my Latino patients, sorry, flipping this around, get vaccinated 22% less than my white patients. Wow, I'm glad to know that. That's good to know. What should I do about this? Okay, so this makes people very uncomfortable, but we should get comfortable with stuff like this. Giving feedback. Other people have alluded to peer comparison. This is a whole other talk I would give about the best way to give feedback to doctors. So there's a whole other talk I can give about how you would actually feed that back. And some of this is baked in. So this is just showing that we did a peer comparison intervention in 47 primary care practices, and giving doctors information about their antibiotic prescribing compared to their peers in a particular way is effective in reducing antibiotic prescribing. And I think we need to do the same thing to advance equity. Workforce diversity. So I got this survey today. So I just added this slide this morning. where we are part of an NIH grant at Northwestern to enhance the diversity of our research investigator workforce. And, you know, I got asked these questions, right? I believe recruiting diverse coworkers benefits everyone. Okay, so here I am standing in front of you and like I've given all of the right answers, right? But there's an irrefutable literature that shows like this is true. Okay. I believe preferentially recruiting underrepresented minority faculty unfairly discriminates against others. Disagree. And so on. So for our colleagues who are uncomfortable with this, right, there's an irrefutable body of evidence that more diverse teams come up with more better solutions, more creative ideas, and like in the business world, like make more money, like literally make more money. So okay, and then a couple of colleagues of mine and I, and this is a little bit more particular to academic medicine, but this is about workforce diversity. And again, a whole other talk, but how in our own, you know, here I am, a middle-aged, gray-haired white guy talking about diversity, equity, and inclusion, but actually like thought about some prescriptions about like how those of us who might be from the majority group can help diversify our workforce. And then finally, last two slides. This was mentioned this morning. So advancing health equity through antimicrobial stewardship. And I was, again, similar to what I showed you with the CDC workshop that happened in September, you know, I was so hoping that one of the speakers at this thing was going to have like the answer. And I looked through and like, here's all of the, you know, here's all the people who are going to present there. And I know, you know, I would say I know like half the people here and have heard almost like half of them talk in terms of like podcasts and webinars. Anybody's ever that I heard so far has ever gotten as far as I just took us right now. So like, let's think about this some more. Okay, so and I'm sure this will be great, but we need to do more thinking and work about it. Okay, so let me stop there. I did go 7 minutes over, sorry. But let me stop there. And in particular, let me go back to this. Like, what do people like? And even if you all this talk just makes you profoundly uncomfortable, feel free to share that. But what thoughts or comments or questions do people have? Too overwhelming? Is this like even like this will never ever happen at my institution? Sorry. Yeah. Yep. Okay, so the comment of insurance, and for that I would come back to. So let me mention Otube Essien's his work in atrial fibrillation. So he did a nice series of studies where he looked at people with private insurance or not, big black-white disparity in the proportion of patients with atrial fibrillation who get the newer anticoagulants. And he's like, okay, well, let me just look in among Medicare patients. They all have the same insurance. Guess what? That disparity is still there. And so he said, okay, well, now let me look in the VA, where not only does everybody have the same insurance, but everybody has the same access to the same pharmacy. So surely there won't be a disparity there. Same disparity. So it's not so necessary, but not sufficient, I would say. Yeah. What? Yeah, please.
Look at my family members and I feel like when they go to the doctor, they're actually telling the doctor that they want medication. I don't know if that's a polite thing or, you know, and maybe why don't do that, or minorities don't challenge their physicians as much as whites do.
Could be, or you're showing up to the visit with more like I show up to the visit with more social capital for whatever reason, because and the presumption is there that I want an antibiotic and like something happens that, so it could be, and it, you know, is it white patients explicitly or implicitly asking for more antibiotics and getting them, and the physician being influenced by that more because of differences in perceived or real social capital. Could be, but I think we need to sort of unpack that. So that probably, that belongs in there too. With that probably is in the bias, splitting out the bias box.
I think it is more with convincing communication with the doctor. When the patient needs to go there, how do they communicate with the patient themselves, and how can they, convince the doctor that I need an antibiotic? Some of the different.
Yeah. Could be. Other thoughts? I'm keeping you here for 4 more minutes, so you got to say something. Please.
I work in a skilled rehab facility, and there is really a lot of unfortunate patients, and we get a lot of prophylactic antibiotics. I was recently in Guatemala with 4 surgeons from California. Absolutely no prophylactic antibiotics.
Yeah. So that's just different, different location, different treatment. So the resources could be different, but but it is interesting that, of course, my mind immediately is like, okay, well, what's the reason? Like, what's the reason? But if you felt like there was no reason, those drugs were still available and not given, that is interesting.
I think lawyers play a big role. Lawyers and the lawsuit.
Okay. Okay. But you're sort of, are you implying that like white people show up with like, we show up with a lawyer in our back pocket, or perceive as having a lawyer in our back pocket?
Going through the paperwork and doing afterwork after that. I mean, they will be behind them thinking that, what else I can do? Why didn't do that? What is the problem with that?
Yeah.
I think there is a,
Yeah.
There's also, the U.S. has a lot of lawsuits. Everybody wants to sue everybody. When I was in Guatemala, they were just grateful and happy to get care.
Yes, there is, but there's also a really good literature that lawsuits happen when patients, something goes wrong and they think you're a jerk. Like that, there's a JAMA paper from like 20 years ago that like, it has nothing to do with actual clinical appropriateness. It's like something has gone wrong and you're a jerk about it, is how you wind up getting sued. Yeah.
I think to kind of piggyback off, I was thinking about your flu vaccine, right?
Yeah.
To think about that. I think there's a trust in the medical
Yes,
system.
thank you.
And I think that maybe that falls under bias, but there's got to be a better way to kind of unpack that like generational trauma.
Right. And so actually, for those who couldn't hear, and thank you for saying the word trust. Like I did not mention that here. I'm definitely thinking about it. And as I look at my, my disparity in influenza vaccination rate, trust is sort of a big thing. And I, do I have more implicit trust with my white patients than with my Black patients? Definitely. So does that fit into bias? And that actually also very quickly gets us to, who are these things tested on? Who is present in the workforce? Getting back to the issue of trust, 100%. Thank you for bringing that out explicitly. You got 2 more minutes of torch, or 1 more minute? All right, hearing none. Okay, it's late in the day. I know we all have to get back, but thank you for attending. Happy to stick around and talk about this. And again, like you have now thought about this as much as anybody in the world. So like, help me do this, and let's like write a paper about it or something. Okay, but thank you all.
Okay, just